Daniel, he will speak about the impedance-pH monitoring and its utility of esophageal disorders diagnosis. I encourage the participants to send questions to Daniel at the end of his speech. Thank you, Daniel, so much for your participation here. We cannot hear you, Daniel. Please open your...
Can you hear me now?
Yes, thank you. Yes.
Okay. I will share the screen. Can you see my screen? Hello?
Not yet, yeah.
I'm trying to share my screen, but I don't get it.
Probably, Fernando, are you here? Can you help Professor Daniel?
Okay, just 1 second, please. I will do it again. Share screen.
Please click in share screen.
Yep, I will do it. 1 second, please.
No problem.
Now I am showing my screen. Can you see it?
No, we don't see.
Okay. When I go to share, I cannot get it shared, so I will cancel again. And I go down to share screen, and then it's asking me.
Probably it's open for me.
For whom is open?
Yes.
And now, share.
Oh, yes. Daniel Sifrim is here.
Can you see the screen now?
Yes.
Yes.
Okay. Thank you.
All right.
Okay.
So, can I start?
Yes, please.
Okay, I will repeat my introduction. I would like to thank the organizers for inviting me to this meeting. I will discuss today with you the use of impedance-pH monitoring and its utility in reflux disease and also in other problems like belching or rumination. So this is a video that shows how impedance works. This is a catheter that contains a pair of impedance electrodes, and you can see that the impedance drops when the bolus is passing through. You can see it again. It's a very interesting video because the subject swallows, and what happens at the very beginning is a rise in impedance and then a drop. And the rise has to do with entrance of air and a drop with passage of the liquid bolus that is involving the two impedance electrodes. I show this for the last time. Okay. So if you imagine the situation where you have, instead of only two electrodes, you have multiple electrodes and the bolus is passing, what you see in the impedance is a sequence of drops and recovery, drops and recovery, drops and recovery, and this is moving in a up oral direction. Here is the mouth, here is the stomach, and the liquid is moving in that way, and you can see the movement of the liquid as a impedance drop and recovery. Now, if you are in a opposite situation where the liquid is moving from the stomach upwards, like in this situation, in that direction. So what you see is a drop in impedance, but in this case, moving from below in the stomach up to the mouth, and then recovery. So this is what impedance shows during a swallow of liquid, and this is what impedance shows during a reflux of liquid. Now, if we combine the impedance measurement with a pH measurement, and we see a reflux episode of liquid and a little bit of gas because of there is this spike, and there is a pH drop that crosses the threshold of 4, we are talking about an impedance reflux episode that happens to be acid. In contrast, if you have again a liquid reflux episode, but in this case the pH does not cross the threshold of 4, we are talking about a weakly acidic reflux. And if there is no pH drop at all, we are talking about alkaline reflux or weakly alkaline reflux. The combination of these two types makes what we call now non-acid reflux. Now, impedance has some advantages compared to pH-metry. In first place, it distinguishes between acid, weakly acidic, and non-acid reflux episodes. That helps to correlate non-acid reflux episodes with symptoms, which improves the possibility to make diagnosis of reflux symptom association. As I will show you later, impedance is able to assess movement of gas in both directions. And now we are using impedance to measure two novel parameters. One is the mean nocturnal baseline impedance, and the other is the post-reflux swallow-induced peristaltic wave, which are parameters that can help to better phenotype the patients based on reflux monitoring. And finally, impedance can be used both on or off PPIs, whereas pH-metry, either catheter-based or wireless, can only be used off PPIs. Let's have a look at a couple of examples of the usefulness of impedance. This is a pH recording. You can see this is 0, this is 9, and the line is pH 4. In this case, there are drops in pH below 4 that can be considered by pH-metry acid reflux episodes. However, if we add the concordant impedance tracing, you can see that these pH drops are associated to very peculiar patterns of impedance changes, which are not swallows. They include gas because there is a rise in impedance, multiple increases of impedance in the 3 times. So if we do a pH-metry alone and we don't know this, we will consider these drops in pH as part of the esophageal acid exposure. But what is this? When we expand one of these episodes, we see that there is a continuous drinking of liquid containing gas. In this case, that is a fizzy drink, is Coca-Cola. So in fact, the patient was drinking Coca-Cola, and that provoked these pH drops. I am giving this as an extreme example, but the practical use is that when we are performing a test, we need to look at the meal periods and try to make sure that the meal periods that are marked in the recording, that they correspond with the timing of the meals and drinking and swallowing, because many times the patient does not push the event marker properly, and many times part of the acid exposure is due to wrongly establish the limits of the meal period. So this is the first step in any impedance pH-metry analysis. The second issue concerning detection of reflux episodes is the possibility of detecting non-acid reflux. Impedance detects non-acid reflux, and in patients that are refractory to PPI treatment, this can be a cause of refractoriness. Patients are symptomatic in spite of a high dose of PPIs, and they are symptomatic to non-acid reflux events. Sometimes their symptoms are not related to any reflux. Now, what is a non-acid reflux episode? This is a typical impedance tracing. These are the drops with swallows, as I mentioned earlier. This is a pH recording in the esophagus. This is a pH recording in the stomach. And you can see that there is a pattern of reflux in the impedance recording without a change in pH. This is a typical non-acid reflux episode. Is it relevant non-acid reflux? Well, it is not very relevant for mucosal damage. You will not have esophagitis or Barrett provoked by non-acid reflux. But it is relevant for symptom perception in patients with refractory disease. It is relevant in respiratory disorders with bronchial aspiration of non-acidic contents. And it is relevant in hypersensitivity to non-acid reflux. If you have 100 patients with reflux symptoms, you will see that 35 of those will have erosive disease if you perform an endoscopy, and you have 65 that will not have esophagitis or Barrett. Within this group of non-erosive reflux disease, there is a group that has hypersensitivity to non-acid reflux episodes. This cannot be detected by pH-metry, cannot be detected by catheter-based or wireless pH-metry. Of course, you can say, well, but this is a small group. Well, if you have millions of people with reflux symptoms, 30% of refractory patients, out of this 30%, 15% might be sensitive to non-acid reflux. That is not a negligible amount of subjects. The other important area where non-acid reflux is very important is in pediatrics, and particularly in neonates. The diagnosis of some respiratory disorders in neonates suspected to be secondary to aspiration of gastric contents or reflux can be made by impedance and not by pH-metry, because most of these regurgitations are non-acidic because the stomach in these infants is full of milk. And there is an enormous amount of episodes of retrograde flow of non-acidic contents that can end into the lungs and provoke severe respiratory disorders. It is very well known, and pediatricians are using impedance to detect non-acidic reflux. So this is an important use of impedance technology. Now, I mentioned that there are patients in which you don't have a conclusive diagnosis of reflux disease based on endoscopy and pH-metry. For example, they have an acid exposure of 5%, or they have around 50 reflux episodes, and the endoscopy shows an esophagitis grade A, and the symptoms are not particularly typical. So you want to know if the mucosa of the esophagus is healthy, is very healthy, or it is somehow touched by reflux. And impedance can give us a hint on the status of the esophageal mucosa. If you have the impedance catheter with the electrodes in the esophagus and there is a swallow of there is liquid, the impedance will reflect the ionic composition of that liquid, and if it is a swallow or if it is a reflux site. In contrast, when the esophagus is empty and there is no liquid, no swallow or no reflux, the impedance electrodes are touching the esophageal wall. And the esophageal wall has its own electrical conductivity is increased, the impedance is reduced. In other words, when the mucosa is leaky and there is a lot of ions moving around, the impedance is low. When we look at the tracing, an impedance tracing, at a period in which there are no swallows and there is no reflux, what we are looking is at this situation. The situation where the electrodes are in contact with the mucosa. In a normal subject, the mucosa has a high impedance, around 3000. In a patient with esophagitis, the mucosa is leaky and the impedance is lower, below 1500. In the middle, the patients with non-erosive reflux disease have a lower baseline impedance, but not spectacularly lower. So in some patients, we can think that the baseline impedance is low and that the patient might have non-erosive reflux disease. This is a study from Germany that showed that in patients with erosive disease and non-erosive reflux disease, the baseline impedance is below 2000, but you can see that there is a pretty good overlap, where a patient with functional heartburn have a baseline impedance in general much higher, similar to healthy subjects. So to put it in a simple example, if I have a patient with symptoms, they do not respond to PPI, endoscopy is negative, and the acid exposure is 4.5. And I want to know if the patient has functional heartburn or NERD. Having a baseline impedance below 2000 is moving the balance more to the NERD side than to the functional heartburn. And this is measured during the night because this is the period where there are less swallows and less reflux. We make a measurement of the night recording of the baseline impedance, and that is why we call it mean nocturnal baseline impedance. There is another parameter which is relatively new, and I find it very interesting. This is a reflux episode detected by impedance, and this is a pH, and the pH goes down. So this is an acid reflux episode. Notice that a few seconds later, after the reflux episode, there is an impedance drop that moves all the way down and coincides with an increase in pH. The only way that this can happen is whether this swallow brought some bicarbonate with saliva to neutralize the acidified mucosa. Now this swallow here that brought saliva is a reflex induced by this reflux. In healthy subjects, the majority of reflux episodes are followed by a reflexed swallow, 15 seconds, 20 seconds after the end of the reflux. It takes some time to stimulate the salivary glands to produce a little bit more of saliva that provokes the swallowing reflex, and that saliva brings bicarbonate to neutralize the acidified mucosa. This reflex is called post-reflux swallow-induced peristaltic wave. And in healthy subjects, this is pretty common. More than 60–70% of the physiological reflux events are followed by this swallow within the first 15–20 seconds. In contrast, in patients with reflux disease, this reflex doesn't work very well. In many patients with esophagitis, there are only 20–30% of reflux episodes that are followed by this swallow. In NERD, is around 50%, and the difference is not that large. But when the put together the MNBI and the PSPW as parameters to help to make the diagnosis in a subject which has a negative pH metric, the acid exposure is normal, the reflux symptom association is negative, the endoscopy is negative, and they want to know if this patient is really symptomatic due to reflux or not. When they apply the PSPW and the MNBI, they find that the sensitivity and specificity is very good. Now let's move to another topic. Every time that we swallow food or water or whatever, and we swallow some air. Why? Because in our pharynx there is a dead space that is filled with air. And every time that we do a swallow movement, that air comes into the esophagus, into the stomach. This is a typical swallow, and you can see the bubble of air there. Now, we can see with impedance that when we swallow, there is air because the impedance rises. This is a meal period, another meal period. You can see that during the meals, some patients have a lot of air swallowing. This is what we call aerophagia, in Greek, swallowing air. Now, this is important because these patients might have, after the meals, reflux episodes associated to belching, and that belching might be increased because of the air swallowing during the meals. This belching related reflux is unlikely to respond to PPIs. This is the same period amplified, and you can see how many spikes we have during the meal. And if you expand even more, you can see that each of these spikes is air moving downwards. So in our group, we identify a group of patients with refractory symptoms to PPI treatment that have exactly this. Aerophagia during the meals, increased number of liquid and gas reflux postprandial, non-responder to PPIs. Detecting aerophagia with impedance is very useful because this has a relatively typical treatment. Now let's talk about belching. This video is not very easy to see, but you can see that there is a catheter inside, and the catheter is surrounded by a relatively dark environment. If I run the video, you will see that at a certain moment it becomes white. Now, you see that the environment becomes white. That white is air, even more white. This is air surrounding the catheter. And now there is a swallow or a movement that is emptying the air. All right, so let's see it again. I will stop it when I see the belch. Now, this is expressed here. A rise in impedance induced by air. And then there are two spikes. And then there is a peristaltic sequence that is clearing the air. You will see it now. The tail of the bolus of air is moving, like Dr. Ghoshal explained you earlier today, is a contraction here eliminating the air. And this is what we see here. This is an impedance volume clearance of liquid and air. So impedance can help us to evaluate movement of air. And there are different possibilities. this, as I said, is a liquid moving down. And you can see the drop in impedance moving down. In contrast, this is air moving down. The subject is swallowing air. This is what I showed you earlier as aerophagia. However, this is another situation where the air is moving up. So this is air coming from the stomach, moving upwards. And finally, there is the most interesting of the models is air that is moving in and out within the esophagus. This air never reached the stomach. So this is a liquid swallow, this is aerophagia, this is a gastric belch, a typical belch coming from the stomach, and this is a supragastric belch. It's air that is coming into the esophagus and it is eliminated out of the esophagus. Now let's have a look at this situation. This is a subject in which the pH metry shows many short-lasting spikes of pH drops. Many. A significant amount. Maybe 30, 40, 60 spikes of pH drop. What is this? Too many short acid reflux episodes. Even perhaps the total acid exposure is normal. Well, these are all spikes in the impedance tracing. Spikes in the impedance tracing. And most interestingly, the patient marks with the event marker many symptoms. These are symptomatic episodes. Each of these marks is one symptom. So, if you see many acidic reflux episodes, many spikes in the impedance, and many symptoms, there is something strange. These are not typical reflux episodes. These are supragastric belches associated with acid reflux. Each of these is a supragastric belch. Supragastric belching is a behavioral disorder that happens in general in young patients and is either expressed as a non-stop belching or as a increase in acid reflux that the patient do not realize that is due to his own belching. Very important to diagnose with impedance because the treatment of supragastric belching should be done not with PPIs, not with anti-reflux surgery, but with cognitive behavioral therapy and or addition of baclofen in low doses. This diagnosis cannot be made by pH metry. This is another situation. Again, this is the pH metry. Interestingly, there is a region here that is full of symptoms and not many pH drops. Another region there. So if I look at the impedance, this region happened immediately after a meal. So there is a meal here, and the patient has a lot of symptoms and many reflux episodes detected by impedance. All these are non-acidic retrograde flows of liquid. Most of them are recognized by the patient as regurgitation. This situation is until recently was considered a failure of PPI treatment in young persons that persist to have postprandial regurgitations. And we have recently analyzed a large set of these patients with postprandial persistent regurgitation in spite of PPI treatment. And we found this pattern of a significant number of non-acidic symptomatic reflux episodes, and this is rumination syndrome. Rumination syndrome can be very clear by the anamnesis. The patient is vomiting without effort immediately after the meals, or, and this is the most critical problem, can be hidden within the spectrum of reflux disease not responding to PPIs. We are finding more and more of these cases of hidden rumination in refractory reflux in young, particularly ladies, that we diagnose afterwards as a ruminator, and they respond pretty well to cognitive behavioral therapy with diaphragmatic breathing. Finally, I would like to share with you what we think at the moment. This was published a month ago. What are the best indications for impedance pH monitoring? This was a comparison versus wireless pH monitoring, or Bravo. The first, as I said, is in patients with refractory typical or atypical symptoms despite PPI therapy, where there wasn't evidence of reflux disease before, and now we want to know why the patient is not responding to PPIs. So, refractory patients not responding to PPIs with previously documented reflux disease, they should be studied on PPIs with impedance pH method. Second indication, patients with respiratory symptoms or a respiratory disease that is potentially triggered by reflux. For example, cough, or a respiratory disease that is prone to deterioration from reflux-related microaspiration. This is very typical in pulmonary fibrosis, cystic fibrosis, and after lung transplantation. In these cases, the best technique is impedance pH metry rather than pH metry, because non-acid reflux is very common aspirated. As I said, in patients with repetitive belching, with or without concurrent typical GERD symptoms, and this is to identify aerophagia plus postprandial gastric belching, treatment of which is reducing the aerophagia with diet and potentially baclofen, from supragastric belching, which is a behavioral disorder that needs to be treated with cognitive behavioral therapy. And finally, the new indication is in patients with postprandial regurgitation in spite of PPI treatment. This patient might have rumination syndrome. So I discussed today with you the principles of impedance, the best relationship between impedance and reflux disease in terms of relevance of non-acid reflux, relevance of mucosal integrity measured with MNBI, and relevance of mucosal clearance as a measured with impedance with PSPW, the relevance of impedance in the understanding of belching and aerophagia, which is a universe that has been completely ignored or impossible to measure with pH metry or with Bravo, or even with mucosal impedance, in which you cannot see reflux of air, of course. And finally, the possibility to diagnose rumination. Thank you very much, and I would like to share with you a very beautiful picture that is always in my heart. Thank you very much.
Marcelo's, no sound.
Unmute, Marcellus.
Yes, yes, I'm.
Okay.
Thank you very much for your fantastic presentation. I'm waiting the question for the participants. Um, One question is, what is your opinion about the duration of the pH monitoring? 24 hours is the best time, or we need more time to know what is happening in the esophageal disorders?
I must say that the ideal scenario will be more time. More time. And more time you can have with wireless pH metry. So I think that in patients where the symptoms are much more intermittent, not every day, and the symptoms are very typical, heartburn or chest pain, I will not be against the use of wireless pH metry for 72 hours or even 96 hours. But in patients where the symptoms are more atypical, are more frequent, are related to a little bit of belching or respiratory disorders, I think that a good 24 hours impedance pH metry will do the job. The two techniques are not competing with each other theoretically. One has an indication and the other has other indications.
Perfect. I have a question. In your opinion, how the artificial intelligence could be used for interpretation of pH impedance studies? Or
Can you repeat it? I missed the for
yes,
2
sorry.
words.
In your opinion, how the artificial intelligence could be used for interpretation of pH impedance studies?
I
What is
think it is the present. It's no longer the future. I am involved in 2 projects. One on the measurements of impedance baseline and with artificial intelligence, and another for detection of supragastric belching with artificial intelligence, which is time consuming and difficult. And they both are doing very well. They are now yesterday submitted to DDW abstracts. I think that this is almost the present. 1 or 2 more years, and the artificial intelligence will be doing the best job in analysis of. The problem with impedance pH metry is that it is time consuming to do a good analysis. A rough analysis, everybody can do it. You push a button and you get a report. But that rough analysis doesn't give you what we expect from impedance, the difficult cases, the problems. And for that, it takes a lot of time. How much? 1 hour to analyze a tracing. Well, people does not have 1 hour every day to look at this. So artificial intelligence will facilitate that. I'm convinced.
Miguel, Carla, Professor Ricardo, do you have a question for Daniel?
It's interesting. Professor.
Sorry.
Go ahead,
Just
Professor.
a brief comment about supragastric belching. Usually it's a benign condition, but it may cause of damage to the social life, professional life of the patients. One of our patients, when they first came to the clinics, she was about to lose her job in bank branch. She was threatened by her manager of firing because the loud noises she produced at her workplace. So it's sometimes it's important to recognize and try to correct by behavior therapy, as you said, Daniel.
I agree on that, and I think that these severe cases are a drama for the patients. My new message today is that in parallel with the severe cases where the belching is the problem, there is hidden supragastric belching in patients with reflux disease. You cannot imagine how many patients with reflux disease have reflux and symptoms of reflux, heartburn, associated to a supragastric belch. At this moment, we believe that 30–40% of patients with reflux disease might be having this problem. That was ignored until now. So there are like two dimensions with supragastric belching. One is a case that you mentioned, and I think that this is dramatic and we need to recognize and help. But the other is the hidden problem that I think that is very, very common.
I quite agree, yes.
Thank you very much, Daniel. Miguel, do you have a question or go?
No, go on. Go on. Let's go on.